Hey, hello everyone. Yes, so my name is Aonghus Ryan, and I'm here to talk to you about relational difficulties after acquired brain injury. Here are the aims for the session, sort of as advertised. An accessible overview of human attachment in children and adults. Why do relationship problems cause such distress and not just in patients? Common causes of relational difficulty after acquired brain injury. How neuropsychological formulation and intervention can help, and what to do if you suspect there is a relational problem to be addressed in a client that you might be working with. Before I forget, please do use the Q&A section, which is the black bar at the bottom of your screens. We'll come to the questions at the end, but by all means, during the presentation, if something occurs to you, you just stick it in there. Okay, thank you. Before I get into the topic, I wanted to share a bit more about me and how I came to have this particular interest within the field of clinical neuropsychology. So it was when I was completing my doctoral training in Oxford that I kind of became aware of a gap between the predominant form of therapy, which was CBT, and what I was seeing and experiencing in the clinic room with my clients and patients. I was very lucky then to have been able to combine my curiosity about other forms of therapy with my passion for neuropsychology in my final year elective placement, where I gained experience applying different forms of therapy, ones which place human attachment at their heart, all with patients with acquired brain injury. This experience spurred me on to specialize in one of these forms of psychotherapy called intensive short-term dynamic psychotherapy. I won't say too much about that at this point, or in fact during the talk, but just to note that this is a form of therapy that puts human attachment and human relationships at the center of the intervention. I've also trained in something called emotionally focused couples therapy, and again applied this with people with brain injury. And since completing my training in clinical neuropsychology in the University of Glasgow, I regularly teach on a different clinical neuropsychology program at Canterbury Christchurch University using these models of intervention. In addition to the core aspects of working in neuropsychology within patients and outpatients, I've been applying these therapies in the NHS and in private practice for over 10 years. So I hope it's fair to say I've been thinking about attachment-based therapies and brain injury for quite a while. I've also published a couple of case studies on the topic, and I'll tell you a little bit about those. The first is about applying attachment-oriented therapies to assist in the emotional reawakening of a patient several years after his brain injury. The second was about using attachment-oriented therapy in the assessment and detection of a subtle form of aphasia in a patient I worked with. That's enough about. So what is attachment? Well, there are different words and phrases for attachment: bonding, connection, nurturing, closeness, love, amongst others. The dominant theory about why young emotionally attached to their caregivers is evolutionary. We depend on our caregivers for survival, for food, for protection, and guidance. It calms us, it allows us to regulate our emotions, promotes adaptiveness and growth. As children, of course, we are wired or programmed to seek proximity to caregivers for survival. Human children are vulnerable for longer than any other species, so this proximity seeking carries on for many years. But this is not just philosophical stuff. It feels like something when we are close to our caregiver or significant other, right? This is a critical issue in attachment-oriented therapies. What are the feelings and what might be getting in the way of closeness to others? Attachment-based therapy developed, a theory of attachment-based therapy was developed in the 1960s based on the work of British psychologist John Bowlby, who proposed that strong early attachment to at least one primary caregiver is necessary for children to have a sense of security and a supportive foundation they need to freely interact with their environment, to explore and to learn from new experiences, and to connect with others. And based on his work, Bowlby described 4 different attachment styles: secure attachment, anxious attachment, avoidant attachment, disorganized attachment, and attachment styles which inform individuals' relationships in adulthood. I wanted to take just a moment to talk through the square, the sort of 2x2 graphic on the right of your screen. So just imagine, obviously they're intersecting. So the top is the model of self for the child, and in parentheses the level dependence, the level of dependence. So if we start, and then on the left the model of other, so caregiver, parent, and the level in parentheses of avoidance that the parent is engaging in with the child. So if we start in the top left, so the securely attached child will be one who has low dependence needs and has a positive model of self, so feels positive enough about his or herself, and corresponding on the other axis where the parent has a positive model of the child and is at low avoidance, is not avoiding the child. Okay, so that then generally is a good setting for a securely attached child. If we go down to the bottom left, a dismissing sort of situation is one where, even though the child might have a broadly positive view of themselves and their dependence needs are low, so they're not very frequently seeking parents, but nonetheless the parent has a negative view of the child and is highly avoidant or is dismissing or is not able to deal with the child effectively. So in that case, we get this dismissing situation, where often a child will learn to withdraw from the caregiver. Okay. The top right then, preoccupied. So the settings for that typically are where the model of self for the child again is negative in this case. So they're not sure about themselves. They have a negative view. I'm a bad child or something like that. And where the dependence needs are high. So frequently seeking the parents, frequently seeking the caregiver. When the parent, has a positive regard and has low avoidance, what you can end up with a child who is preoccupied, so maybe anxiously seeking out caregiver quite frequently. Okay, and then the last and the least pleasant to contemplate, where there is both the child has a negative model of self and high dependence, so it's frequently asking or seeking parent, and also where the parent has a negative view, a negative model, negative view of the child, and is highly avoidant. So these can be, very chaotic parent-to-parent-child relationships where you end up with a child who's often quite frozen or just quite chaotic themselves, so internalizing that chaos. So it's got unpleasant things to think about, but this is a very solid theory and it's extremely widely used. Mary Ainsworth then is also on this slide. So she also significantly contributed to our understanding of attachment theory by developing a procedure known as the stranger situation, which helps to assess attachment styles in infants by observing their reactions to separation and reunion to their caregivers in sort of somewhat controlled settings. And again, using this sort of 2x2 to get some sort of sense of what the parent-child relationship may be. So, why do relationship problems cause such distress, and not just in patients? Well, we probably all have our own answer to this based on our own experiences. And of course, as we've just seen, we each have our own experiences and related tendencies. So it's no surprise that there'll be a range of viewpoints. I want to be clear that my starting point is that for most people in adult romantic attachment, we are encouraged by our programming, our biological programming, to bond. I realize that not everyone might agree with that and may make different choices, of course, but the biological and evolutionary evidence suggests that this really is the case. You know, sometimes in psychology, things can be very abstract and quite intellectual. We speak of thoughts and behaviors, rather dry, abstract concepts. But relationships, the good parts and the bad parts, are not about abstract, dry concepts. No, they are about the experiences. They're about what it feels like to be with someone else, be that parent, partner, or friend, or foe. And this is the key point of attachment-oriented therapies. The starting point is the frustrated longings, the wants, the disappointments, the seeking to connect or reconnect, the need for a safe base, and that these things drive the cognitions and behaviors that we like to talk about. And in attachment-oriented therapies, we focus on the experience that the person is having, the in-the-moment feelings that can be really powerful and revealing. And then to answer the question, it feels like something too when our longings to connect go unfulfilled. Why does it cause such distress, though? Well, the predominant theory is that we are programmed to experience these powerful feelings. It's nature's way, our evolution's way, of letting us know how important it is to connect with others. As we will see, a brain injury can disorganize so many of the foundations of adult relationships. Now, I'm going to beg your indulgence here with this graphic, which shows different levels of emotional processing in the brain. I hope it will help to explain something about why relationship problems hurt. It's to do with the concept of bottom-up influences on behavior. What do I mean by bottom-up here? Well, if we say that we are programmed to bond, to love, to mate, and to procreate, and we accept that it generally feels good to do these things, then where do the good feelings come from? I can answer that. It's from hormones and neurotransmitters. Love hormones like oxytocin that get released by mother to help baby with bonding, but also exist in adult relationships. Exciting neurotransmitters like dopamine that motivate our exploration, and pleasurable neurotransmitters like serotonin, and peptides like endorphins, the morphine of the brain. The argument is that these are the levers nature uses to encourage us to behave in ways that are consistent with the survival of the species by making it feel good when we do. In the graphic, the bottom-up influence on cognitions and behaviors are the emotional systems in capitals at the bottom. They are considered subcortical, so right at the bottom of the brain, hence bottom up. Also right in the ancient parts of the brains that we share with other mammals, and also where the hormones, neurotransmitters, and peptides I just mentioned get released. The top-down influence, by contrast, relates to problem solving, inhibition of responses, the ability to be measured and controlled, and this is largely neocortical, the top, or more accurately, the outer layer of the brain. So thanks for bearing with me with that one. I'm going to come back to it a bit later in relation to attachment-oriented therapies. Okay, so now for something a little different, we're going to try a sort of poll or a quiz, I think, Kate, on this question: which causes most relational difficulties after brain injury? Okay, so the answer is apathy. I don't know how you guys did. It's by no means, irrefutable fact, but there's a lot of evidence to suggest that it is actually apathy that's associated with higher levels of carer burden and distress. So for the non-injured party, that's what's often most troubling. Um, why this is, I think, is very interesting in the context of our presentation, and I'll come back to it a little bit later to explain why. Um, all the other things that were on there, as you may have guessed or understood, all of the other things, of course, are also um, very much correlated or associated with relational difficulties after brain injury. And I suppose the key message is that all of them do affect relationships, and also that many people experience these problems simultaneously or in very short order in the context of an acquired brain injury. Luckily, there's a very recent review that I thought would be useful to look at, which had looked at common causes of relational difficulty after brain injury. And we're going to spend the next few minutes going through these 4 slides. So it's busy, but I'm going to talk you through it. So this one, actually, the top of the screen is missing. This one is about stroke. I can't see that part of the slide. So the researchers have categorized difficulties after stroke, which are associated with better or worse relationship quality. Okay. Just to note, they've used the ICF classification. That's the International Classification of Functioning, something used by the World Health Organization. And they've used a set that's understood to be most relevant to people who've had a brain injury. So bodily functions, those 5 boxes: bodily functions and structure, activity, participation, environmental factors, and personal factors. And as you'll see, red indicates something that's negatively associated with relationship quality. Orange, mixed findings, and green, mostly positively associated with relationship quality. The black circle, or if the circle is filled in, sometimes it's red. That means it's something within the injured partner. And if it's an empty circle, it means it's a factor that's relevant when it's happening for or in the uninjured partner. So if we just start on the top left, so I suppose unsurprising things. So things within the body function and structure, so physical and sexual problems, cognitive problems, socio-emotional problems. I suppose that would make sense because that's very related to relationships. Aphasia and anxiety within the injured party, and also anxiety within the non-injured party, associated with poor relationship quality after stroke. The next column, sleep problems for both, fatigue for both, personality changes, of course, very significant. Behavioral problems in the personality and behavioral problems in the injured party. Mood problems for our stress or our anxiety. I mean, I'd say they're probably the same thing. But in either party or in both parties can be very much associated with poor quality of relationship. Activity, so you guys are probably reading this yourself. Activity, so problems in sexual relationship, of course, that's going to impact a relationship. That's for both partners. If the person is particularly dependent, that can be associated with poor relationship quality. If there's communication issues, I suppose distinct from aphasia, it would seem, though of course they are likely to be related. If they're working together, that means they're in a business. And caresses, I thought this was very nice. So communication, working together, and caresses are really positively associated with relationship quality after stroke. And in terms of participation, being at home more can be negatively associated. Role changes, of course, a very common thing we encounter after any ABI. And that's for both, because obviously it's changing with one, it's going to change for the other. But being socially active for the injured partner, associated with good relationship quality and spending quality time together from both sides, associated with positive outcomes. The environmental factors, I'm really not quite sure why medication is here, but or in fact really what that means. I have not unpicked that one. So medication, perhaps it means the amount of medication that the injured partner is receiving can be negatively associated with relationship quality. The help of professionals positively associated, and that's for both. It speaks to the need for therapy for families. Having young children, and there's another fact later about the age of the injured person, negatively of the high demand, so negatively associated with quality. And country residents have left it in black. I looked to see if they explained what black meant, but unfortunately they didn't. And then we come lastly on to the personal factors. So negatively associated things like hypervigilance for both, which will be, of course, related to anxiety, being unable to understand the partner's experience for the partner, and insecurity negatively associated with quality. Low level of education, relationship commitment, a good relationship before, feelings of love. I really like that they've put both the caress and the feeling of love. So it really brings it to life. And feelings of gratitude, often, I suppose, for maybe someone having survived a brain injury, positively associated with relationship quality. And then sex and coping strategies in black. Was not clear exactly what they meant with the black ones. This slide then is about factors associated with relationship stability after stroke. And you'll see they just touch on participation and personal factors here. So in red and under participation, we're seeing it being unable to reach agreement on reciprocal role. I suppose that is very much the same as the role change, and why that might be negative for relationship stability. I understand from reading the paper that they just have participation in personal factors because they've only selected studies that look at stability, as opposed to more a broad palette for the relationship quality question. Personal factors, again, low level of education, negatively associated with relationship stability, as is caregiver burden, or divergent expectations for either. Feelings of love, commitment, and high quality of pre-stroke relationship positively associated with relationship stability. So the same authors have done the similar study looking at a traumatic brain injury. And unfortunately, they have not used the color scheme here, but hopefully it's helpful just to have a compare between the stroke and the traumatic brain injury. They're very similar things, though the lists are shorter here. So in body, this is relationship quality after traumatic brain injury. I'm terribly sorry, that's an error on the slide. It's after traumatic brain injury. So physical problems, personality changes, so all stuff we've seen in the first slide of this sort. Behavioral problems, mood problems for either. Sexual functioning, cognitive problems, socio-emotional problems, and psychiatric problems, which was not previously mentioned. In terms of activity, again, it's repeated: sexual functioning, communication, and for participation, role change again, both societal and family role change. It's interesting that they distinguish this time, and spending time together for the injured partner is relevant. Environmental factors, so family support, having children, social support, and supportive professionals. Again, not color-coded, so not very helpful, but similar themes. Some will be positive because supportive professionals was positively associated in the previous slide. Personal factors such as age, length of relationship, strength of the pre-injury relationship, feelings of love, commitment, and coping strategies. Again, it would seem that most of those would be positively associated. On the last slide of this type, so factors associated with relationship stability after traumatic brain injury, behavioural problems, so body function and structure, so behavioural problems, functional deficits, and mood problems. Functional dependence, again, negatively associated, I believe, from earlier. Being financially or socially dependent, another factor negatively impacting relationship stability. Environmental factors, so having children together, We're not sure if that's a positive or a negative. I suppose there's going to be more commitment, but young children, we know from earlier, was negatively associated with relationship quality. And again, the range of personal factors. Here, ethnicity for the first time, occupation, relationship length and feelings of love, respect for partner. Gender, again, first time we've seen that as a relevant factor. Educational level, we believe, was negatively associated. Pre-injury mental health, I imagine, also negatively associated with relationship stability. Commitment, acceptance, and hope for improvement, again, likely to be positively associated. I will allow you to read these quotes for yourselves. The first, then, making the point that reducing contextual stressors, including relational problems, can improve overall outcome. And the second quote more clearly stating the implicit but very significant support that a committed partner can offer, and how a change in relationship can affect that. If you lose your partner, then you really do lose something extremely helpful and practical for you, which with impacts for your recovery. And from this one, from the paper, Predictors of Marital Stability 2 years after traumatic brain injury. So going back to that I mentioned in those busier slides earlier on. So the odds, the likelihood of being more unstably married were much higher for younger patients than older patients. I suppose that it draws in lots, including how committed the relationship is, whether there are children, and so on. Well, I wanted to say a little bit then about how neuropsychological formulation and intervention can help. Well, we start often, as many of you may know, with highly skilled, it's a multifactorial formulation. It's a critical element drawing on a range of sources, so including personal history, the neuropsychological profile, stage of recovery is very important, attachment history, as we've seen a little earlier, understanding both in terms of the person's own early attachment, where might they be, for example, on that 2x2 from John Bowlby, or also the attachment history of the couple. And that can really include, very importantly, I think, in vivo assessment of the dynamics and the interpersonal dynamics, I mean, there. That observation, as I said, of the dynamics of seeing what it's like when they're both in the room, and what is it like for the psychologist or the therapist to be there. And it must be said the neuropsychologist is particularly well placed to include the specific nature of the cognitive or personality or motivational changes into the relationship. And we'll come back to that apathy point before long. And this, of course, all has the potential to lead to real benefits to relationship quality and stability, for ongoing support from the stable partnership, as I just mentioned. Of course, what we're doing with formulation is generating hypotheses of what do we think might be going on for the couple. Is a couples therapy, for example, indicated? Or in this example, could it be, in fact, that fatigue is a predominant factor, making everything worse, so leading perhaps to verbal aggression, with, of course, an expected relational impact on a non-injured partner who, for example, may have their own trauma history. So, it's just to give you some sense of how we might link these concepts together in our formulation, to think about, well, where might we then intervene, and to test the hypothesis. How do we assess and treat relational problems after ABI? It's difficult to go into too much detail within the scope of the talk, but as I mentioned, understanding the pre-injury attachment style and the attachment history is very important. This can guide therapy. So what's, for example, triggering for the non-injured party. It could be apathy, which I keep advertising, and we'll come to. It could be verbal aggression, where a non-injured partner has said their own trauma history. Perhaps they've been in a relationship previously that was unpleasant, or there was verbal aggression, and it can just be very triggering for that person. Of course, it would be for anybody, but just in maybe particularly triggering for that person, and understanding how that's playing out with the couple. Of course, we can help with psychoeducation, so we don't have to go in on a very informed terms of psychotherapy. It can just be at the level of psychoeducation, can be very helpful, of course, because the non-injured partner and the injured partner, they won't have expertise in brain injury and how it might play out in relationships. And all of this can guide in vivo interventions, be that in the psychotherapy space, or on the ward, or with teams working with the family, or as I say, in couples, or more formally, family therapy. Coming back to this slide, this graphic, if we stop to think about what psychotherapy is, and what is required for any of us to make use of psychotherapy, it should become clear that it is perhaps at the very top of the most complex task any human can engage in, because it's about self-discovery, about self-knowledge, about painful acceptance and forgiveness or grieving, about letting go, and worst or best of all, about turning this into new habits and behavioral patterns, or new ways of relating with other people. It really is like right at the top of the tree in terms of personal human endeavor. It is the mother of all top-down processes. The person who has just gone through a sudden life-altering injury or illness involving the brain faces into these tasks with significantly diminished resources, including, of course, the very cognitive tools they would wish to employ. They may also have impaired self-awareness. It follows that for a significant section of people with acquired brain injury, it can be very difficult to use top-down strategies. Attachment-oriented therapies can be particularly helpful in allowing for primary emotions and giving primacy to some of the deeper bottom-up processes which are seeking expression. Okay, after all the advertisement, earlier on I said that I thought that the fact that apathy was at the top of the list for caregiver burden was particularly interesting. But why? When I have seen it in couples therapy, it can sometimes be interpreted by the non-injured party, the non-injured partner, in the following catastrophic way. They don't care about me anymore. They're not even trying. That's the interpretation sometimes, and understandably, by the non-injured partner, who, of course, doesn't have brain injury expertise. This amounts to what we call in couples therapy, we call it an attachment injury. That's something like akin to like if someone had an extramarital affair, or if we're just consistently very seriously let down by a partner. We call that an attachment injury. So sometimes for the non-injured partner, it can be interpreted that way: apathy. They don't care. They've given up, and related, they don't care about me. So on the basis of that interpretation, it can become a relationship ending, or at the very least, a relationship threatening trust issue. And one of the reasons, I suppose, is it's a problem is because it is such a sudden change. Maybe that's obvious, but it's a change in the person's presentation, which the non-injured partner has to try to make sense of. Of course, bear in mind from that graphic I was showing you, it may be their own, primary processes, their own, very powerful emotions are getting triggered by this change and trying to make sense of it. As we saw from Bowlby's work, one simple way to assess differences in attachment style is on the basis of whether the child seeks out the caregiver or withdraws from the caregiver. And these basic moves towards or away from, pursue or withdraw, are highly relevant in couples. And this is what this slide is getting at. So the pursue, the upregulation, the seeking out of the partner, so it's one set of behaviors, or the withdrawal, again, like that Bowlby, the 2x2, some children will withdraw or down-regulate, seek to maybe self-soothe, take themselves away from the parent, or in this case, adult relationship, from the partner. What this slide then is doing is taking the issues that we mentioned in that sort of brief quiz, where we would ask you to kind of guess which was the most distressing. I'm just taking those and putting them into the box of, well, is this pursuing or withdrawing? So in apathy, of course, it would seem on the surface like someone's consciously withdrawing, right? And that's why it's problematic. And of course, perhaps that person was somebody who was the pursuer previously. They would be the one saying, hey, what's going on? You know, they were that person in that relationship. So the change is the issue. Aggression, of course, a complicated issue, which we'll come and talk about in a little while if there's safety issues. But aggression is upregulation, isn't it? Somebody's pursuing, they're agitating. Hey, what's going on? So it's a kind of, they're upregulating, not down-regulating. So that, again, but that could be a massive change in a couple's relationship, where perhaps the person who is now aggressive was the person who previously was withdrawing. It had that tendency in the relationship. Aphasia, of course, it's a communication issue. It's a barrier in and of itself, but that might again just feel like, for the non-injured partner, that the person is not as present. Or of course, with aphasia, it can be the person learns to not try to speak. Role changes, as we said, so that typically, of course, will be a withdrawal from somebody who was carrying out some role, but then they're no longer doing it. So that's it. Oh, they're gone. They used to do this for me. This was an important part of our relationship, but he's not doing it, or she's not doing it anymore. Personality change, it sort of depends on the personality change. Of course, often it will be maybe a disinhibition. We will often talk about personality change like that. But sometimes personality change can be, again, somebody who is withdrawing more, or is more wrapped up in their own head, for example. Social cognition too, so the ability to understand, to mentalize, the ability to understand what somebody else might be thinking. That's social cognition. What's this other person thinking? How am I relating to them? How are they relating to me? So I'd say really, I suppose, it can be both. It can be a misread of a social situation, or a situation in a couple that leads to a disagreement or a misunderstanding, where you've got two people going further apart. But sometimes maybe the person has had so many, with social cognition problems, have had so many bad experiences with their partner or with other people that they begin to withdraw. Or maybe the misunderstandings in terms of social cognition are leading them to want to withdraw. And mental health problems, again, anxiety does tend to lead to avoidance. Depression, the two most common mental health problems, again, tending then someone to switch off or to be withdrawing. So I hope that's helpful, just to give a sense of how these sort of aspects might change how somebody is behaving in the relationship, and how that might be interpreted, and leading to relational difficulties. So what to do if you think there is a relational problem with the client that you're working with? What I would suggest, first and foremost, is to get engaged in some information gathering. It's a sensitive area, of course, but please don't be afraid to ask questions about relationships. They can be very mild questions, like, how are you guys getting on together, or how are things at home? They can be very mild questions, just to sort of at least know that the person you're working with can have that invitation to open up, and then you can gather some information. Again, the attachment injuries, as I mentioned, so you may already be aware of attachment injuries that have occurred from just without even meeting the person from reading the notes. So, of course, these can be things which we've not mentioned yet, like sexual disinhibition, where, of course, the injured partner might proposition others, or more extreme disinhibition, perhaps earlier on during the rehab journey. Could be other impulse control problems that might be causing attachment injuries, gambling, or increased addictions. Sometimes patients, the patients present in what I would call emotionally regressive ways. So they may feel a bit childlike in terms of how they're managing some of their emotions. They may be more fragile, more prone to deflecting or blaming, which things, of course, which often co-occur with limited self-awareness or denial of deficit. And then last, we've mentioned before several times, I've just gone over, but that negative behavioral problem. So apathy being one way to understand it, but of course, demotivation, a closely related term. I think it's a good idea to also check, how is the relationship going? Not just what's happened, what are the bad things that have happened, but actually, are these guys talking to each other? The things that are positively associated or with good outcomes in relationships. If you've been able to talk it through, just try to, if a problem's been brought to you, so, well, what's happened? How did you work it through? So it's okay just to ask these, again, open general questions and see, gather information, because that might be very useful to other people, of course, working with the team, with the family. It's also sensible to check if the non-injured partner is attributing behavior to the brain injury or to some other cause. So, they're really getting back to that interpretation. What do you understand is happening? And that can be really useful information, particularly for a psychologist or for a professional to maybe think, oh, maybe we do need a psychologist, because though they can be very entrenched, right? Those views like, oh no, he's given up. Okay, and they can be very entrenched, and sometimes they do need that skilled intervention to sort of try to unpick or understand where it's coming from. What to do then if you suspect there is aggression or violence? And just a little note before, obviously, if you do think there's aggression or violence, speaking to clinicians who are aware of the specifics of the case is critical, and this is not to replace that, but just a few ideas. Okay, so obviously, if you're aware that anything's happening, you have to address it. It can't be ignored. You have a duty to do that. Of course, it's a highly complex area. The mental capacity, in particular, where somebody may be back at home, but maybe their mental capacity is not always there, or is fluctuating. If we agree with that concept of mental capacity fluctuating, it can also be related to do with problems of reduced levels of responsibility. Those things go hand in hand. So actually, this person may have somewhat diminished responsibility, but of course, there is still a non-injured partner or a family, or maybe even be children who are witnessing it, or at the receiving end of verbal or physical aggression. What's important, I've found in my experience, is just to keep in mind that the people who the family may be coming into contact may just not have that understanding, may not even know that in fact that the person has had a brain injury. So that's always very useful, I think, just to put that out there as context for any intervention, be that the police, be that social care or other services. If you're not a clinician, I would really strongly encourage you to speak to a clinician, ASAP, if you've kind of detecting aggression and violence and it's not already understood that that's happening, or there's no plan about it. That's because almost all clinicians really will have had some training, in safeguarding and risk management, and they'll be well placed to sort of advise you. Obviously, taking notes is really important, particularly in this sort of context. If you think someone's in imminent danger, of course, again, it's your sort of duty as a citizen, I suppose, as much as anything else, to make that call. If you're in doubt, you should be calling the emergency services if you really think someone's actually, in imminent danger. The duty, of course, to inform the GP. Really good idea to reach out to your local NHS brain injury services, of course, community safeguarding, and maybe community psychiatry too. But again, speak to the clinicians involved, and they'll be able to guide you through that if you're not a clinician yourself. And as repeating myself, but just to keep that brain injury forefront in communication, because all services will often have that little experience with brain injury. We're just coming towards the end now, so thanks for your attention. Just to say, there is hope. There's this really lovely piece of research commissioned by Headway, you, me, and the brain injury relationship changes after brain injury, and this is percentage of reported relationship improvements following brain injury. So as you can see, nearly half of family members, so about 45%, actually reporting some improvement in their relationships. Employers not so much, but it's not all negative. Sometimes people, I expect many of us will have experienced it, where people are often just very grateful that the person has survived, and that they're there, and that they can relate with them and continue to have a life with them. And then related, I suppose, if you are wanting to do some more reading about relationships, Headway have got just a range of fantastic resources. I couldn't recommend them really highly enough. Very thorough coverage of this particular area. So just Google that. And lastly, if it really piqued your interest, unfortunately the conference just happened quite recently. The Ahead Together conference. It focuses on families after brain injury, and it's a really excellent conference. I could highly recommend that if you wanted to I suppose meet like-minded clinicians or people working in brain injury. Okay, so I'm going to stop sharing the screen, and I think we'll have just a bit of time for Q&A. Thanks for your attention.
So we've had 3 questions come in, Aonghus. One of them says, aggression in the long term would be difficult to cope with versus apathy, ? So just a question about, the differences between those two.
Yes, it's a great point, and it's always, with all these things, it's going to be case by case, right? So, and that's, I suppose, where the formulation comes in, with all of that experience, as how heterogeneous the group is. And of course, the research on apathy is talking just in the general. In the general, it seems that actually this is the one that specifically causes caregiver burden and relational distress. But that's in the general. Of course, sustained aggression. I suppose maybe people there tend not to be very sustainable situations if there is high levels of aggression and it's ongoing. I think that absolutely they would leave. And I suppose I'm trying to caveat the research evidence to say this is what it's saying, but of course all of those things, and aggression in particular, and very high cause of care burden and distress. Not to downplay it. It's just that's what the literature says.
We've just also had a question if you could give a couple of examples of problem with social cognition.
Yeah, sure. So the related concepts, overlapping concept really is mentalization, with a theory of mind. Sorry, 3 different concepts. But theory of mind deficit in autistic spectrum disorder. So the way we assess for that, there's multiple ways we assess for it, but what we're looking for is so the overarching ability is to be able to, as I said, imagine what the other person might be thinking, and that then is kind of the foundation of that is different elements. So one is almost like an imaginational task, being able to hold in mind that the other person may have intentions and ideas, but also emotional recognition is another part of it. So can you actually pick up on the emotion from the other person? And that can obviously relate to lots of different abilities that may affect that ability to literally, like, oh, this person looks happy, this person looks angry. And that can also be related to tone of voice. So it's not just facial expression, or am I picking up on inflection or tone of voice? The other aspect then is being able to predict what the other person might be about to do. So is the person able to use behavior to understand what might be happening. And another part of social cognition is about social rules. So somebody may have lost the ability to understand what's appropriate or what's not appropriate. Now, I know you asked for examples, but I just wanted to kind of break down social cognition first. So, um, so misattunement is often what social cognition problems look like. Sorry, I said social anxiety, social cognition problems. So you may see that where in couples therapy, I've seen it a lot, where the non-injured partner may be looking at the injured partner and almost imploring them, to say, respond to me, right? If the person is like not tuning in. And so you can feel this almost like a sort of gap or a chasm right between the couple in the room where they're trying to connect, show emotions. They're maybe crying, but the person is just kind of not quite able to tune in and go, "Oh God, are you okay?" So it's that even on a very what might feel like a human level, even just to kind of notice and go, "Oh gosh, what's happening?" Of course, where I'm talking about people who are couples, so you expect even more tuning in a healthy relationship. So that's what it can look like, a kind of lack of tuning in. But it can also look like social faux pas as well. One of the tests we use, the faux pas test, which is just basically someone putting their foot in it, just being very clumsy socially or interrupting, not taking turns. It's almost like maybe a bit like someone who's had a couple of drinks. So you kind of, well, you feel that sort of tension when they're in the room and maybe with a group of people they're just not reading the room and it feels like, oh, what are they going to say next? So there hopefully there's a couple of examples to bring it to life a little.
I think that was really helpful. Thank you. And somebody's made a comment about attachment-based therapy needing a lot of effort from the partner. But I mean, given your last answer, it seems like all of this needs a lot of effort from the partner.
It does absolutely. You need these therapy without brain injury. It takes commitment and effort. Yeah, absolutely. I suppose if there are relational difficulties, you would hope that you would hope that at the very least, as I guess that the non-injured partner is wanting to try and save the relationship, because that's really what's in question, isn't it? Is it going to survive, or is it just going to be ongoing but be awful? Um, so but you're absolutely right, and I think a lot of the sort of the contracting at the beginning of any couples or family work is relates to that, relates to commitment. So couples therapy should always be having a conversation with both people individually first to have that frank conversation. It's like, actually, where are you? Are you committed to this? Is this like last chance saloon, or is it no? There are issues, but I really want to work on it. So that giving time for that is critical in couples therapy. Yeah, thanks for your questions.
Okay, I think there's just the final question, which might be a good one to end on anyway, is just your kind of top tip for supporting clients or their loved ones who are really struggling. What would your advice be to the participants of the webinar who are broadly from medico legal, case manager, clinical
Yeah,
background?
just so normalization. I know it's always a bit of a loaded one in psychology. What's normal? I don't mean it that way. It's more the normalization of mental distress. And if we just step out of the ABI world for a moment, like that's what we as clinical psychologists will always approach any mental health problem from a normative stance to say it's normal for people to have very mental health problems in life because it's quite common. And so similarly, when somebody goes through a situation or an experience like they're doing, apps just normalize it and say that's absolutely understandable. It's quite it's common, and there's help available. We can try and get you help for that. So I think that'll be the top tip, is just to allow for it, give it a bit of time. Hopefully, some of the questions or tips that I've added would help you in terms of knowing what sort of thing to say. But allowing time and space for someone just to be heard, I think that's any human can offer that. Stop what you're doing and go, all right, I'm really sorry to hear that. That's actually quite common. What's happening? So sure, show interest, show curiosity, and then you have to be guided by what's coming to you, of course. And of course, if it's aggression, or but in terms of how much hope you want to say, oh well, we can get you help, or how much assessing how much a problem it is. Of course, you need to know your boundaries. but just to normalize it and to comfort them and be human. Allow yourself to just kind of stop what you're doing for a few minutes and try to just relate to them as a human being. That's definitely going to help them.
Wonderful. Thank you so much. That's the end of the questions. So
Brilliant. Well, thank you very much. Yep. Thank you, Kate, for your help.
thank you very much, Dr. Ryan. Thanks everyone for joining us. Bye-bye.